Welcome everybody this afternoon. My name's Rachel. I work for Northamptonshire Community Foundation. Delighted that you could join us this afternoon. This is what we know as a Brucey bonus, or in modern parlance, an Easter egg. We are very lucky as part of an offshoot of our community conversations around the global goals to have Clinical Director of Prevention and Mental Health for the General Practice Alliance, Dr. David Smart, joining us today. David is a specialist, also a retired general practitioner, and he is going to share some very, very specialist work that he's done in recent years in collaboration with a range of other mental health champions across the country. This forms part of the work that we've been doing around supporting, working together to look at local solutions with philanthropists, donors, funded community groups, concerned residents, to see how we can make Northamptonshire the best sustainable, well and happy place to live. And I won't talk too much further than that, apart from to say I'm delighted to introduce our Good Health and Wellbeing champion for this global goal, Sandy Godoy Messenger, who will tell you a little bit more about the work that we've been doing around good health and wellbeing. And while she does that, I will cheekily pop into the chat box a link to her brilliant blog around wellbeing, which I do recommend that you read. And just incidentally, whilst David is doing the presentation, we will be collating some questions to ask him at the end. So do pop in any comments or questions and we will do our best, and David will do his best to answer them duly. Over to Sandy.
Thank you, Rachel. Hello, welcome everyone. I am Sandy Godoy Messenger and I'm the Administration Services Officer at Northamptonshire Community Foundation. As Rachel mentioned, I'm also the staff champion for Good Health and Wellbeing. And as you may or may not know, it is World Wellbeing Week as of today. So at NCF, we recognise the importance of wellbeing, particularly in staff morale. I know the last year has been really, really hard for everyone. So we've taken part in lots of wellbeing activities over the last year, such as a Zoom art therapy class. We've been growing sunflowers, we've done a step challenge, plenty of quizzes. So if you've been doing any wellbeing activities or plan to do any for World Wellbeing Week, please feel free to share that in the chat box as well. So to kick it off, we have Dr. David Smart, who has kindly put together a presentation on mental wellbeing pathways for Northamptonshire in addressing the global goal UN SDG number 3, good health and wellbeing. So at NCF, we have made a commitment to embed the global goals into our work to improve the quality of life and wellbeing for all by 2030. We've been running a series of community conversations since October last year, covering a number of different goals, where we've invited a panel made up of community groups and donors and trustees to discuss how we can work towards these goals, what we can do next, and how we can support each other. So in the last Good Health and Wellbeing community conversation, we had discussions around tackling the stigma around mental illness and wellbeing. We're working with donors and partners to break down barriers around mental health and wellbeing, especially in the workplace and the private sector, including the promotion of a workplace wellbeing charter, and working with donors to direct funding and address male mental health and suicide. We also discussed preventative investment, and we will commit to funding projects that support proactive wellbeing management to help prevent people reaching crisis, including working with young people and children and utilising outdoor spaces, otherwise known as the Natural Health Service, which is an ongoing piece of work. We've recently launched the Global Goals programme, which has been made possible by the Constance Travis Endowment Fund. So this will enable community organisations across the county to think global and act local. So this rolling programme offers grants of up to £3,000 to organisations working to achieve the global goals of no poverty, zero hunger, good health and wellbeing, quality education and gender equality. So as our community conversations continue throughout the year, more goals will be added to this list, and you can keep up to date with this on our website, which is ncf.uk.com. So without further ado, I'd like to give a warm welcome to Dr. David Smart. So over to you.
Oh, thank you so much. Thank you, Rachel, and thank you, Sandy Godoy, and thank you to people joining. And I'd notice John Nightingale is on the list, and Susie Van Hayden from the Good Life. So it's nice to be with people who have actually been part of this journey. And I think it is a local journey, and I'll be talking about the place of the place approach we've been doing in Northampton and how we've been linking this across. And as you can see, next Tuesday, in fact, we're going off to see whether how we've done with the award, and that's really exciting. But this picture in the middle, really this person-centered approach. I've had my own episode of mood disorder, and so I know a little bit of this personally, and with my family as carers of 3 family members who've been suicidal and 2 admitted. So I know this journey well of what's needed around the person, a person-centered approach, the family, close context, but how we link all of this together. And this is the key thing of how we can work locally, and some really very innovative work, not just by myself, but by a lot of other people, including the mental health collaboration and collaborative that is developing. So this really is the goal of good health and well-being, and goal, the SDG 3. And it's interesting, when I looked into this, I thought, well, where's mental health in here? There's well-being, but we always kind of, health and well-being seem to come together as pairs. What do we mean by that? So when the health and I'm old enough to remember when the well-being boards were set up, health and well-being boards were set up, and I asked that question, kept asking, what does well-being mean? And I will just pose that to you, because I think it means mental well-being, and there's a really good evidence base about mental well-being being linked to health, and we can actually clarify a little bit on this. But it's only in 2015 that mental health has really come into the UN SDG in a major way, but it is included, and that is really important to see it included in non-communicable disease prevention and some of the goals around this. And the World Health Organization are asking some specific goals to be included around suicide, suicide rates and access and coverage. And I think these are 2 things, and I will come back to the coverage issue later, particularly around depression. So this is a little bit of, I looked onto the website this morning, and this actually, the 7 things around the accelerator aspects around this whole aspect of stronger collaboration, better health, and around healthy lives and well-being. And interesting enough, my presentation was going to cover most of these. It doesn't cover too much on the aspect of 5, the innovative programming in fragile and vulnerable settings and disease outbreak response. But I will cover the bit that I think we actually have a syndemic, and I'll tell you what that means in a moment, rather than the pandemic. And that's a key thing that we just need to really think through. COVID has revealed the inequalities agenda like nothing else, and the reality that we really need to address these. And that's really brought them to the center. And I think we've now got an opportunity to work in partnership to address this. But I will hopefully be covering, some aspects around primary care in particular. I see that as obviously perhaps a bit of a bias there from being a GP, but I do see that as central to how we can actually begin to think of how move forward. And then, or hold health, because I think a good personal relationship with your primary care provider actually really matters to our health. But also, I do really think this aspect of community and civil society engagement is something we really need to be looking at. And in particular, what I call a left shift of funding, moving from the acute trust where it is, and moving into the primary care and community, and especially into the voluntary sector, who we know have been really hard hit with COVID in funding, and we need to address that capacity in funding. 7% of the NHS budget lies in primary care, so 93%, as you can see, lies elsewhere, mainly very much in the acute trust and some into community trust. But the other bits I do want to just touch on are digital and research, because we've got some good opportunities. Now, I love this slide. I have shown it to other people before, because it comes out of a report, which is a fantastic report. At the top, you can see the title, the Foresight Report of Mental Capital and Wellbeing. And this slide sums up our human trajectory from, you can almost say, almost prenatal, so almost kind of sperm to worms. We kind of go right from prenatal all the way through to beyond in grief and dealing with the aftermath in our communities after this. But this trajectory is first 1,000 days of your life matter the most, and it's your bonding relationship with your loving parents, or you hope they're loving, because that really matters. And then, so you hope you've chosen your parents wisely. Your genetics, 50% of your happiness, according to Seligman, comes from your genetics. So choose your parents very wisely. But then that care, but early abuse or trauma, we know that early adverse events in childhood decreases that trajectory. Certainly also drugs and alcohol affect your brain development. And this is how you will see the rest of your experiences as you develop your executive functioning of your brain. And then as you come across into further things, your social connections really matter, and that's going to help you in your midlife stress and issues that you have. But you can see down the left-hand side here how biology really matters, and chronic inflammation, we know more and more, matters to so much of our bodies, to diabetes and the metabolic syndrome, to cardiovascular disease, but also to mental health. And things like gut inflammation or gut issues and bacteria, not to say inflammation, but gut, can have an effect on inflammation in our bodies. So a handful of nuts a day, provided you're not allergic to them, can actually decrease inflammation, and so can some of the oils we eat. So this really matters as our chronic inflammation. Also, sleep matters hugely to our bodies and how we recover, and even to the aspect of preventing dementia and other things in later life. And so sleep, exercise really matter, and eating. And these are things that we can all hopefully begin to think of taking some personal action on. And certainly as a GP, I recognise people who came in drinking 2 cafetières of coffee a day, not surprisingly a bit anxious, and significantly helped when they stopped, gently. But the other things of interaction, how we are social animals and how we need to be thinking about social prescribing, and I'm going to be talking quite a lot on that, and our cultural values. And we know that these cultural values are changing, and some are good and some are, as we move into more some individualistic ways, I would say are wrong and damaging to mental health. We do need to see ourselves much more as part of a community and much more compassionate to each other rather than competitive. This slide, I think, is one of the most important, which is that COVID is a syndemic. It was described in the Lancet, and he described nothing less than national renewal is needed. That was the editor of the Lancet, one of the most evidence-based medical journals there is. But it's because we worried about the death rates, rightly. We're worried about the interruption of healthcare, rightly. But it's this fourth wave, which I think is the biggest and most worrying thing that's going to be coming on. And that's going to have a long tail, 2-3 years, and maybe even longer into our adolescent community. So we really need to be thinking, what are we going to be doing about this? How are we going to be coming and building back better, leveling up, whatever words you want to use? But bottom line is, how do we build back a more compassionate society? And how do we build back a more collaborative society coming together, as we've seen from the UN SDG 3 goals of working together? And that's certainly something that I want to talk about, because I have been a mental health commissioner and seen different silos. We now need to be thinking how we work in partnership. So this really describes a bit of my own personal journey, but I think as a GP, seeing 10 people a day at least in this similar type of issue, was about a third of the workload of a GP. Moving from stress, distress, disease, where we're feeling a bit uncomfortable, into disease, where we've got a diagnosable mental health condition. And we need some expertise from our specialist colleagues, but only about 10% of people actually end up seeing specialist colleagues. 90% of mental health is dealt with in primary care. And sadly, I would still point out, nobody is coordinating this in a really coordinated way. You may think there should be, that common mood disorder should be a high priority. Sadly, nobody is really doing this. We've tried to do it a bit in Northamptonshire, but nationally this is pretty unique. And I think it's strange that I'm being sent off the HSJ to possibly, as a finalist, just about a very simple biopsychosocial response. And I would also add in the word spiritual, whatever that means to you. So I think a biopsychosocial spiritual response is what we need. And that comes from, as I've just described, the well-being report from the Foresight report on mental capital and well-being. So this is a Kupfer curve. This curve is an acute phase of depression, and you go down to that distress and you get your recovery, and we hope there's this post-traumatic growth. In other words, you've learned from it, you've built into different ways of being to prevent a further episode. We know, sadly, that depression is a recurrent condition, and that is partly genetic, but partly trigger factors and partly maintaining factors. What I'm hoping we can achieve, and what I'm going to be talking about, is how social prescribing, using the 10 keys to happier living, or the Great Dream framework, and developing other courses and resources around this, could perhaps develop some early psychosocial interventions to form a bridge so that we don't dip down into this pit, but we kind of are aware of resources early on, early access. And that again talks to SDG 3 of early access in primary care and this holistic approach. And that's what I'm hoping we can achieve in partnership, especially with the voluntary sector. So just to mention this report, because this is important, I sat on the steering group for this, the advisory group, and it then has become the long-term plan for mental health, building into wrapping mental health around primary care rather than being a separate silo. And so really this whole aspect of a core community mental health offer, the network around the new primary care networks, which are developing to provide care in the community of GP practices working together. And so it's really the opportunity to integrate mental health and physical health. So people with long-term conditions have more, such as diabetes or COPD, have more episodes of mood disorder. We need to be looking at how their mental health is administered within that. And also people with severe mental illness have particularly problems with their physical health to the extent they actually die 20 years earlier than the average population. And that relates to their physical health. So that's a real issue we need to address. So physical and mental health really need to be bound together. So Sandy, just if you can just give me some little bit of feedback. So just true or false to these things, and so which one of these is false? I should put it in that way round, because one of these is false. So which one do you think is false? And Sandy, if you can tell me which one people are indicating, or just a bit of feedback in the chat. So depression through completed suicide is the commonest cause of death under 35. Depression is a leading cause of disability worldwide, and approximately 50% of the costs for depression are in Northamptonshire are actually related to activity in 2 general hospitals. An incidence of depression increased by 5-fold. Sandy, could you just give me any feedback in the chat, what people have answered as to which one they think is false?
Not had any feedback yet. If anyone wants to add in the chat.
Just to wake you up, guys, because there are a couple of questions I will pose.
Shall we call them A, B, C, and D, or 1, 2, 3, 4?
Go for A, B, C, D. And
A, B,
so which one do we think is the one which is false? I'm just going to give you just a little bit of thinking time.
Yeah, so the majority are going for C.
For C. Okay. Well, actually, the answer is D, is the one that's incorrect. And that's because the incidence of depression actually increases 7-fold with 2 long-term conditions. So normally in the population, about 8%, depends which way you go. Obviously, in more deprived areas, higher level of depression. But actually, with 2 long-term conditions, which, as you can imagine, as you get above 60, that's not uncommon, then you've got a 1 in 2 chance almost of having some level of mood disorder. So that's just some facts. But yes, the others above are indeed true. Depression now is the 2nd commonest cause of disability worldwide in quality disability years. So just going on to this. So here's some other facts, and as you can see, I'm just going to see if I can just make my, I've got so I had a thumbnail which was blocking my right-hand side of my screen, so I've just changed that now. So depression is one of the major causes of disability and all to overall health. We talked about the workplace well-being, and it is one of the major causes for presenteeism, in other words, that people are present at work, yet they're not functioning at work. And that's a big problem for employers. Employers get a £1 return. If you're £1 investment, you get a £3 return for mental health prevention. So that's a huge number of people with adults who are depressed. We know obviously 50% of childhood, 50% of adult disorder can be diagnosed by the age of 14. So your development as children, thinking back to that graph I showed you earlier and that trajectory, it really does matter. Getting a good care for children, and especially addressing abuse and bullying in schools, big impact in later life. So we do really need to address stigma, and that's great to hear of the work that you're doing at the NCF, and that I say that stigma kills, compassion saves. If you remember nothing else from my talk, that probably is a key message. But how we can actually get this parity of esteem with physical health. And as you can see, the costs to the SDP or the ICS, because I guess we're just going to transition, is about 30 million. So it's a lot of money. And half of these total costs relate to activity in Northampton and Kettering acute trusts. And I've had in 30 years as a GP, probably 3 or 4 people newly diagnosed by those acute trusts of depression. So a lot of activity, a lot of people with depression, but actually how we get that working in partnership is one of the key things we're trying to address. And what we know is that depression itself increases health costs and worsens outcomes. There's more increased length of stay. And for COPD, that you've got a very clear sum of money. And actually, if we address this care with nice guidance, we decrease that cost by about 28%. COVID sadly has made the situation worse. We're expecting about 500,000 new people with common mood disorder. But what we really need to be thinking through, and this was one of the key things, was how we actually address this, overcoming some of the siloed based thinking. So it's common, critical, and the coverage is low. It's actually sadly around nationally, it's about 25 to 30% of the national coverage of people with significant depression actually get evidence-based treatment. And if you think of that with cancer or any other condition, we'd be up in arms about it. And I still feel after 30 years trying to campaign in this area that we're still really not addressing common mood disorder adequately as a nation. And we're trying to do something about it locally. Anne Rackham is one of the directors of mental health service locally, and she's very much in positive view of this biopsychosocial response we're trying to address. So just out of interest, again, a question, what's the ideal size to improve depression management? I'm just going to give you a bit of moment, and again, just a little bit of feedback would be good to kind of get you thinking, but also please do think of your questions as I talk. So which of these would you say is the ideal size to improve depression management? Is it personal action, family, networks around you, neighbourhood, peace primary care network, keep it in health, locality, town, county, country, or all of the above?
It looks like we're all in agreement with all of the above.
I guess, yes, that's maybe I did wonder when I put this slide up whether I should, but no, I think you're absolutely right. Personal action, yes, depression is a personal issue. And as I've said, learning from the experience, it does matter to actually prevent that, but also taking action ourselves. There are things we can do, including hopefully overcoming stigma and people with significant problems getting help and or even advocacy of people supporting them to get help from either GP or mental health services. Mental health services now often are self-referral. So I'll talk, so there's an opportunity to overcome some of the barriers we've previously had. Families really matter, and people around you, your carers can be either a hindrance or a help. And your network, lots of work coming out of some of the Scandinavian countries, really looking at how we can look at networks of care and thinking how that works and better outcomes rather than this individual focus we have in the UK of thinking the individual's wrong or the West. It's actually thinking about the network, how the network can be built around this person, including our local neighbourhoods, primary care networks we can talk about, but it is just health focused. But I think more into locality and how we think of towns or local bits of towns can working together, and councils, a real opportunity, I think, without those local asset-based approaches, building around what works in the community. County-wise, obviously, we definitely need to be thinking this as a county and country. We need to be well managed and well governed. And I'll leave you to your own thoughts on that one. So the place, what does this mean? Again, size matters, but I would argue to some extent that relationships matter more. So networking and communicating, working together and developing shared goals, and that really matter. And again, thinking about what are the end point, what are you really trying to achieve? And so we've been trying to work in partnership, and over the last 2 years, including with key people like John Nightingale. So what did we do as part of, I'm going to talk now about the project and what we did, was develop a case for change. And despite all of that evidence I've really described earlier, really interesting to see how, that really just didn't, it didn't really cut the mustard. Just that evidence isn't new. The evidence around common mood disorder has been around for some time, but we did have some really new opportunities. So new funding going into improving access to psychological therapies, including into long-term conditions. And you could see that evidence base I was talking about around diabetes and COPD, real opportunity there. We've got some new workers coming into primary care, and these are 2 new workers of pharmacists who can look at your medicine management and social prescribers. And in particular, work I've been doing involved with County Council the last 3 years, and we've now got a social impact bond on top of the primary care network social prescribers. So really big push locally around this, but also at the Mental Health Trust, a real opportunity with Dr. Alex O'Neill-Kerr, who was really developing some superb, excellent and almost nationally unique centre for treatment-resistant depression. So people had had a couple of episodes of treatment or gone through 3 courses of antidepressant and talking therapies without remission. So we put all this together as a case and then took it through. But I would argue all of that was helpful, but it wasn't till we really came to a place approach of working with 2 emerging primary care networks that it really has taken off. And this is what we've tried to do. The depression pathway, these are 5 components, and moving from self-care and public health all the way through to the emergency and the acute. And the money is at the right-hand side. What we're trying to achieve is money flowing into the left shift to drive and address this more at an early stage. And so the goal was to develop and implement an optimized collaborative care depression pathway within two primary care networks, and to improve patient outcomes and utilization of health resource. And you'll see a couple of things here. The Great Dream goes through all 5 components of the pathway, and I'll talk a bit more about the Great Dream, the 10 keys to happier living, how that is, I think, a universal offer. But you can actually just see these different components of the pathway and how they were silos. Each of these had separate commissioners. What we need to be thinking now within our ICS or integrated care system is how we can bring these together as one system working together, and really how we can enable appropriate early intervention. Because what we know is as you move up the pathway and get more severe problems, it takes more money and more treatment to get resolution. Early intervention has an earlier effect. So we all need to be pushing into this early accessible care and prevention agenda and working together. But what we did with those particular areas here, we looked at social prescribing, the prescribing formulary, collaborative care, the crisis cafe, just trying to really promote the excellent work of the mental health collaboration, and then how we can actually address frontline staff training in the acute trust. What we know, as I've said, 25 to 30% of people get coverage, and so how we can actually move into addressing stigma, into this high cost issue in the acutes, but how we can bring it back. So what we've tried to do was use our pathway to address that agenda and to try and move things forward. So this is really what I mean by our pathway. This biopsychosocial approach, using the new roles into primary care with pharmacists and social prescribers wrapped around the IAPT pathway. So you have your bio of your pharmacist and antidepressants, your psychological and your social, and then hopefully into community and active, helping people address meaningful activity. So that's what we mean by the biopsychosocial approach. What did we do? We developed some resources for GPs using the 10 keys, which I'll talk to you in a moment. We developed some My Wellbeing Action Plan, which is hyperlinking those 10 keys to local resources. And we then also developed a bit on the tab on the GP desktop so they could really easily access this right from the consultation. Very easy for them then to utilize this wellbeing action plan. Just press a button, up it prints off the computer. You can talk to the patient and scribble on it, or just give some guidance of here are 2 or 3 areas you can take forward, and people could walk away knowing telephone numbers and key contact numbers, and also if things got worse, what they could do. And that's been worked as a treat. We're now thinking of how we could do that with children. The optimized antidepressant pathway, we've literally just relaunched that. The pharmacist gone through renewal and to relaunch that across the county. And that's really which are the best antidepressants to use first time. We know that if you don't get it right, people lose interest in medication. And so actually then, despite having quite severe depression, they just think this treatment isn't working. So if we use the best treatment first time and then help people to have the tailored response and be followed up, then that matters. And also to have the right dose. A lot of people are on not an effective dose. And again, we're just trying to give GPs guidance as how to build that sensible prescribing into normal practice and be helped by pharmacists. Done quite a lot on digital support. We've got a good app called Feeling Good app, which we've used in Northampton. And that's been very helpful, both for primary care staff, recognising that primary care itself, frontline staff, have been massively adversely affected by COVID. And so actually a lot of the frontline staff need help themselves, but also how they can then use this app for patients. And there's other resources which we've developed around this. Increased voluntary sector capacity. We actually did get some funding. We didn't get enough, but we got some. And able then to pass that to mental health collaboration, and they very easily and ably demonstrated that with further funding and capacity, yes, they can provide more care. And so that just demonstrates actually if we are able to shift funding, then we can actually get people help earlier. And now you can see a picture of Delapre Abbey, and we're developing that, and I'll talk a bit more on that later, and also some other digital opportunities and research. We've literally last week found that we're going to are positively confirmed that we're going to be using an alpha stim, which just is electronic device, goes onto your ears, and that can actually decrease anxiety. You just hold it on there for an hour a day doing your normal activities, but that means you don't need medication or talking therapy. So some research, we're hoping that that's going to be positive. This, I'm not going to, I realise I'm not talking to a medical audience very much, but this is our antidepressant pathway, which is just demonstrating it's quite a simple pathway. What we have been able to do is to get guidance that this vortioxetine, this new drug, can now be used very easily by GPs without having to go through to secondary care to get permission to use it. So we're building up this guidance, which is evidence-based, and hopefully that will be more people getting, when they are given antidepressants, they get the right antidepressant first time at appropriate dose. And then I'm not, this just to look at, I'm not going to ask people to think about, because this is a bit of a complex thing, but I'm just going to just, if you look at these questions and think whether you would say this is true or false, that positive well-being, and when I say positive well-being and happiness, I use the two interchangeably, and I'm talking about a condition, what I mean by eudaimonia well-being, which is more that contentedness with life, that sense of flourishing and well-being, rather than the hedonic well-being, which is that quick fix you get when you, I don't know, have a holiday or something nice happens, somebody gives you a present or something, you get a quick buzz. but actually you rapidly dissipate back to your normal way of being. That's hedonic well-being versus eudaimonic well-being, which is more connectedness, and that the connectedness, eudaimonic well-being, very closely linked to health. So here's a few questions for you to muse on, and just to think through. And I'm just going to go through these now. Let's start just talking about eudaimonic happiness versus hedonic happiness. So do come up with those questions, by the way, because I'm coming in to talk now about happiness and well-being, and then the outcomes. So happiness, the advantages to health. So does it matter? Yes, it does. And you can see half as likely to catch a cold. Wouldn't say that's a COVID prevention measure, but actually if you are feeling happier when you're having your immunization, research from science showed you have a 10% increase in your immune response. So happiness matters to our immune system. It also matters to our cardiovascular system. You can see a 50% reduction in cardiovascular event, decreasing in inflammation, as I was talking about earlier, and that is a significant advantage. To the workplace, this really matters to, if we want the UK to be improving productivity, 12% more productive at work, which is why you see these companies like Nike and Google with all of their kind of employee schemes and the gyms. Why? Because it matters to the bottom line. They've worked out that actually companies outperform the stock market when you invest in well-being of your employees. I only wish that was true for the NHS. There was a bit more focus on it for our healthcare partnership, because actually we know that doctors with better well-being perform better and make fewer mistakes. And also for our younger people, if you have better well-being, you have a higher future income and better relationships. To society, more pro-social behaviour. And there are some courses which Action for Happiness run, and they demonstrate this. They demonstrate that if you do the Exploring What Matters course, a 17% gain in people living more pro-social behaviour and more community trust, which is huge. And you're better saving and taking more care, more likely to vote and participate, which is what we want, more likely to be involved in volunteering and less road traffic accidents. I'm just going to spend a bit of time talking about Action for Happiness. This is the paradigm or the menu that we've used with our social prescribing. We basically introduced the social prescribers to this. We then did some training with them, and we've done supervision, and it's built into their outcome measure. So we've tried to really embed this into social prescribing in Northampton. And also to explain to my GP colleagues, this is what we mean by social prescribing. It's a menu. When you go to a restaurant, you look at a menu, you don't eat the whole menu. Well, you may have a go, but you need to just choose what's tasty for you today, what's right for you today. Same here, these 10 may look 10 may be a bit more overwhelming than the 5 ways to well-being, which is the same as dream, same as great. The first 5 are the same as 5 ways to well-being, just slightly named differently and slight nuances. But then the 10 keys form a menu. Small things, and to choose 1 or 2 of these. And so, but each of these has a really good evidence base. So we know that giving, doing things for others, that can really help your connection. It can help your altruism or altruistic behaviors. And it does give you a boost to your well-being. Just for example, giving somebody a smile, that person may then smile and more likely to smile to another person. So your one smile you can give very simply can actually have a ripple effect. Relating, we know we're very much social animals. We know that people who are lonely, and particularly in late to smoking 20 a day, so very damaging to our health. We need to be connected. That's a big issue that we've had to deal with and are going to have to deal with the after effects with COVID. Exercise, eating and sleep, those go together, taking care of our body, those 3, massive impact on health. Trying to champion Northampton and Northamptonshire, really taking a big opportunity of promoting exercise with Northamptonshire Sport. Great partners, and I think it'd be really great to see us doing something significant locally on exercise. Very good evidence base. All long-term conditions are either prevented or helped, and that goes the same for mood disorder, both prevented and improved outcomes, and same for cancer. Prevention decreased by a third, risk of getting cancer, and also your chance of having metastasis after initial diagnosis are reduced with exercise. Big impact. Living mindfully, that's certainly something I've done in my own life, and trying new things out, and then ongoing learning, having goals to bring this together. Resilience, lots of courses on resilience, but I would say look at the 10 keys and think, what do you need to do? Small steps, you can build resilience, and an attitude of gratitude really matters with our emotions and being comfortable with who we are. And lastly, meaning, and I'll talk a bit more on that. That's really, really important, having meaningful activity, and that is the whole aspect of spirituality is growing rapidly in the in research and evidence, and I'll talk a little bit on that later. So how could we did this, we introduced this with our social prescribers, trained in social capital, and developed into their outcome measures. And I've said the Wellbeing Action Plan and template. The other thing we've linked with the IAPT service, really working in partnership with Northamptonshire Healthcare Foundation Trust. And this was one of the community connections. Really, we'd love really to get the other voluntary sector agencies engaged in this, linking in with the Action for Happiness. And we're hoping to run this on a more regular basis rather than just this annual Wellbeing Festival. Why can't we do this more regularly, perhaps even monthly, and really work into localities to help people be aware what is going on in your locality that can work. So very happy to think about that with others. Just going through and coming into to land a bit on the outcomes. I'm not going to talk too much on the outcomes, but you can look at those slides later. But this, I do want you to note the link tree. I wasn't aware, but if you remember that linktr.ee/A4H Northants, you'll connect with all of the resources that I've been talking about to our local Action for Happiness hub, which I chair, but we are now the national exemplar for Action for Happiness, and that's emerging at Delapre as well. So lots of really good things that we can take forward locally in partnership with others, and very keen to work in partnership with others. And some of you are already aware of the Happy Cafe network. We had some funding, a little bit of funding from Public Health, the only funding we've ever had. And that really, and we've used to develop 4 Happy Cafes. Particularly, trying to link up in with people who may not normally be accessing healthcare and partners, and really the opportunity to run courses in those cafes. As you can imagine, that's been tricky in lockdown. So we're doing a monthly online get together, but we do hope at some stage to be able to run courses in partnership with local cafes. And I think that's a real opportunity. Adult education, just had a good conversation with them recently. They're keen to work in partnership with us as well around this. And the courses, there's 2 or 3 courses Action for Happiness run that very good evidence base into the community provision. I just want to touch on spiritual healthcare. The Bishop of Peterborough reached out and asked, because he's aware of the work we're doing, to explore the COVID response. And really interesting conversations that have flown from that. But we developed Wellbeing Sunday, and training went out to each chapter around the diocese. So that's Cambridgeshire, Northamptonshire and Rutland, and lots of good feedback. And that's an ongoing group, really continuing to look at wellbeing and developing the possibility of could churches become wellbeing hubs. And there's a church in each community. And obviously not everybody has a faith, and I get that, but actually the opportunity of working in partnership in your community is something that we can continue to take forward and explore other faiths as well. And they're very open to that conversation. So the outcomes, I'm not going to go through too much of this because this is a bit health focused. But other than to say that really we have developed these strong partnerships for open discussion. And there's now new roles being developed, pharmacists taking on depression clinics, and Julie Curtis is Director for Community Integration. And so she's very positive about this development as well. So good things going on, and very grateful to John. His comment here about the collaboration has enabled to the organisation to increase an aspect around mental health education. But the other opportunities that are here, we're hoping that the patient experience is going to have more choice, and we continue to develop this, and including to make sure people get texts of key telephone numbers. As I say, mental health services now often a self-referral, and how we can therefore decrease waiting times. So this is some of the spread, and we have also spoken locally and nationally, so lots going on. I'm not going to, you can look at these slides for those who are interested, but really want to allow time for people to ask questions. But that's what we hope we've tried to address, is stigma, bringing partners together, and really, to work together. And then this is our hub at the Northampton Delapre, beautiful area, 550 acres of parklands, and real partnership developing with the university. But we'd love that to be a thought centre for wellbeing. And I also am involved in this with Susie Deal. And we're developing I will go back that one slide, a wellbeing centre at the university and training, and that's something very keen to work in partnership with others. And we're developing some courses with the university, which we'd love to be in further contact with others. So this is my last slide, and you can see that picture at the top of the doctor, and that was pretty much us. That sense of people coming in with something, it's going to take time, but with these asset-based approach, that's something we can really help primary care to engage people earlier and to hopefully fulfill that central picture, that wraparound care, which is personalised to the person. So you'd be delighted to hear that was my last slide. So I'm going to stop sharing, and I hope that I'm going to have lots of questions.
Thank you so much for sharing. That was so insightful. We do have a couple of questions. I just wanted to say I loved what you said about how smiling at someone can have that ripple effect. And it's such a simple thing, but it can just have such a huge impact. So I really enjoyed that. So we have one question here from Kevin. He says, we are told how to keep fit for physical health, and many accept this as the norm. How do we get all to understand what actions are needed to support mental health?
I guess, Kevin, that's really my hope, is Action for Happiness is trying to develop a social movement on exactly the 10 keys. The 10 keys have resources for children. So we're very fortunate that our local lead is Peter Harper, who was a child psychologist. We've trained up the child psychologists to go into schools. So the schools have a framework. There are some after school clubs which are now running this, and teachers are now getting help in how to look after their well-being, because they're very frontline and having a massive impact of COVID as well. So I think it simply, to my mind, it is the great dream. Those are the 10 keys that you can really put in. And I think, as Sandy's just said, it's small steps. What we tend to do when we try and do something, we set ourselves a big goal. I'm going to do something. I'm going to change my life. No, just clean your bedroom. I think, just start doing something really small, clean the window, or to do something really small, build on it, and small steps every day. That's what really matters to our well-being. And I can testify to that.
Fantastic, thank you. And we have just one more question from Alex. How do we tackle the stigma of mental health conditions as an individual's problem? I.e., if someone had a broken leg or a cancer diagnosis, they would be expected to cure themselves.
Yeah, I think I understand, because I think what you're saying is that
I meant to say they wouldn't be expected to cure themselves.
Yeah, they wouldn't. Yeah, I was going to say thank you. Yeah, no, I think absolutely right. Absolutely, this is one of the key things that another slide I sometimes show is kind of this aspect. We need to change the way we see the world, but it's not about self-esteem, which is about the zero-sum game, where we actually look at ourselves. And there's so much, our children are always looking at themselves on social media. That is not healthy. We need to be seeing that we're part of a community. It is, so how we can really work in partnership with others. And also, if you're seeing somebody in trouble, just ask, how are you doing? How's it going? We're very good at picking up people's emotions. We pick it up in microseconds, how somebody's feeling. So actually just being able to say, how are you today? But then just really to engage with that person and to then engage them into helping resources, so that, you know, all the charitable sector, how we can work in partnership really matters, and how we can cross refer and cross help each other. But the mental health agenda is at the core of this COVID response. It's going to be the one that's going to be the long lasting thing. So we really do need to see this as a community response. And the work that's coming out from Finland and other countries is quite remarkable about how they're seeing people who are in difficulty, seeing what's your network, and then they have a network meeting and say, what's everybody going to do to help this person in their network? And you can just imagine those richness of conversations that come from that, and support that come from that, rather than us, when we see somebody in mental health problems, we lock them away or we push them away. We need to be doing the opposite, and we need to be thinking in networks, and that's a really good evidence and growing. We just need to keep telling people this and sharing what, you know, I've had depression. I'm an expert. I've been, you know, trained in mental health. I've lived mental health. Yet if I can get it, anybody can get it. But it's then what do you do about it? And, you know, if you've got a problem, we need to work together in it. And that's where Northamptonshire and the work, we've got an excellent mental health trust. We need to really, you know, work in partnership there.
Thank you. There's just a couple more comments from Beverly. Thank you for such an uplifting, informative and inspiring call to action presentation. Dr. David, you are smart in profound ways. Wonderful.
Thank you very much. Thank you.
We do have a question here from Julia. Do you have a contact at the Delapre Green Cafe? I work for a domestic abuse charity and the service users would benefit greatly from this project.
Yeah, I'm just thinking, I think you could go through me, you know, because I'm actually a trustee at Delapre. So I think that would, now I could put you in touch. There's a volunteering, you can volunteer at Delapre, so there's a whole volunteering process there. But actually, so my email is david.smart@nhs.net. So there's a david.smart@nhs.net. But that, I'd be happy just to give me an email, drop me a line, and then I can see what I can do. But if you just could put in what your inquiry is about, but certainly for domestic violence, I would love to support. And we know there's a 5-fold increase in domestic violence. We really want to support people, and there's other networks around. And I know Good Loaf do a whole load of stuff as well. And Susie's on the call as well at the moment.
Fantastic. So hopefully, Julia, you've got that email address, but if not, we've got it for you, so we can send it to you. John has his hand up.
David, just to add a comment about stigma at work, one of the things that we found, and with the people that I work with, is you've got to win the hearts of the bosses.
Yeah.
Because if you sell it, if you sell the fact that if we can save mental health being a problem at work, your productivity goes up, etc., suddenly the bosses are very keen. I work with a forensics company dealing with scenes of crime officers and digital investigators. And once they understood that if we could deal well with mental health, the stigma of it goes, and suddenly then the workforce are healthier, they're getting more productivity, and the individuals are feeling well.
Just 3 things to say, John, on that. £1 invested, £3 return on mental health.
Absolutely.
£1 invested in early recognition of depression, £5 return. Yeah. And if you look at mental health, you improve productivity by about 12%, as I was saying earlier. These are key facts. It's a bottom line. And if you don't get it, then you need to get a new financial director, because it's pretty very clear. And in HR, we need to be working with our HR directors to really push that. Mm. Absolutely. Thanks, John. And thanks for your support as well. You've been a star.
So just to say thank you to everybody, and just to pick up a couple of points from Dr. David Smart, it's very, very apparent that depression pathways are woefully under-resourced, and as quite rightfully said, if this was the same for cancer treatment, we would be up in arms. It would be a national scandal. Some key words I took away from there, which relates to very much the spirit of the global goals conversations that we've been having around collaboration, coordination, community and connection. Northamptonshire has an opportunity very clearly to be leaders in mental wellbeing and social prescribing, and this solution of the biopsychosocial approach has obviously been presented, is being tested, and is clearly very successful in developing a new community of practice, of which the voluntary and community sector, I'm sure, has a strong role to play. We know through our Coronavirus Response and Recovery Fund last year and its delivery that we allocated nearly £243,000 to health and wellbeing projects, providing counselling services, emotional support during the pandemic, advice and information, wellbeing activities and packs. And we know that there will be a recovery period as well coming out of the pandemic to deal with the post-trauma, which I think is what your fourth wave was talking about, David, in terms of going beyond the immediate situation. Just a big shout out to our Global Goals Ambassador, Sandy, for doing the introduction and giving you information and an update on what we've been up to. And a big shout out to our next community conversation. As I said, this was a Brucey bonus, an Easter egg. Our next community conversation will be UN SDG 10, Reduced Inequalities, with our ambassador Alex Rex on July the 15th. So do join us. If you have any questions that you'd like to direct to David that you haven't thought about in the here and now, and you just want a bit of time to reflect and think, then do pass those questions over to us, and we will direct you to David to be able to answer those for you. But in the meantime, thank you for joining us. Stay safe and well. We look forward to continuing the conversation.